Bismillahirrahmanirrahim. Alhamdulillahirrahmanirrahim. As-salatu wassalamu ala rasulillahi sallallahu alayhi wa sallam. Assalamu alaikum wa rahmatullahi wa barakatuh. My friends, welcome ladies and gentlemen, brothers and sisters to the latest installation of the Intellectual Discourse at INCEIF or ID at INCEIF series for the second one this year, entitled Medical Takaful in Malaysia, Navigating the Cost Crisis. My name is 𝗖𝗍𝗘𝗜𝗙, and as usual, it is my pleasure to be your MC for this event. And thank you for those who have joined us here live in person in the INCEIF auditorium on campus, as well as those who have joined us online on Zoom. Now, speaking of Zoom, let me just go through some brief housekeeping before we kick things off. For those who are joining us online, please do submit your questions in the Q&A window below, and we will have our moderator today to pose the questions to the speakers during the Q&A session later, inshallah. As well as for those of you who are in person here today, please do wait for the mic to be handed to you during the Q&A in order for our online, for the benefit of our online viewers, so that they can take your questions as well before posing your questions to the moderator or the speaker. And for today, we have quite an interesting topic, as mentioned, Medical Takaful in Malaysia, Navigating the Cost Crisis. And the speakers that we have today, starting from on the stage from my immediate left, is Mr. 𝗧𝗸𝗀𝗂𝗂𝗂𝗂𝗂𝗂𝗂. He is a teaching fellow at INCEIF University. Mr. 𝗠𝗲𝗱𝗶𝗶𝗄𝗏 Zainal, he is the Group CEO of 𝗧𝗸𝗃𝗃 Takaful Malaysia, 𝗠𝗃𝗶𝗴𝗁. Welcome, sir. Welcome to INCEIF University. And Ms. 𝗬𝗓𝗓 Syafiqah Mukhlis Mudaris. She is a research associate, of Khazanah Research Institute. Welcome, ma'am. And our moderator today is Professor Dr. Amir Shahruddin. He is the director of the Center of Excellence Islamic Social Economics here, Islamic Social Finance here at INCEIF University. Without any further delay, I would like to pass the floor on to our moderator, Prof. Dr. Amir.
Okay. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And good afternoon, everyone. Welcome to our the latest intellectual discourse on navigating the cost crisis of medical takaful crisis in Malaysia. I'm honored to be your moderator for our today's discussion. First and foremost, I would like to extend a warm welcome to all of you who have joined us here in person. And it's wonderful to see many faces, and I can feel the energy in this hall. And also, I would like to acknowledge and welcome our online participants. We are greatly appreciated to have you with us, and we hope that you find our discussion today engaging and insightful. And as briefly mentioned by our brother 𝗍𝗍𝗓𝗂𝗂𝗂𝗂𝗂𝗓, today our focus is on a very critical and important issue about the cost crisis related to medical takaful. As we know that our medical costs are increasing at a very alarming rate, and this has impact on both the takaful operators and the policy holders. So our aim from this discussion is to understand what are the causes underlying this increased cost of medical treatment, and we like also to discuss about the strategies how to manage and mitigate this cost increase. So we have gathered a distinguished panel of experts who will share their insight and strategies and to address these challenges, and more importantly is to ensure the sustainability and also the growth of our takaful industry. So we have first our panel is Ms. 𝗬𝗓𝗓 Syafiqah Mukhlis from Khazanah Research Institute. Research at KRI focuses on public health, digital health adoption, and the care economy in Malaysia. Ms. 𝗬𝗓𝗓 holds a master's from Imperial College of London in the field of translational neurosciences. And our second speaker is Mr. 𝗠𝗲𝗱𝗶𝗶𝗃𝗏 Zainal, Group, CEO of Syarikat Takaful Malaysia Keluarga Berhad, and Mr. Azman brought with her very vast experience in life and family takaful industry for about more than 28 years. So before joining Syarikat Takaful Malaysia Berhad, he was the CEO of Takaful Malaysia and also 𝗡𝗃𝗶𝗴. And our third panelist, who is our homegrown guru in Takaful from INCEIF, 𝗠𝗃𝗶𝗄𝗂. So 𝗠𝗃𝗶𝗄𝗂 has wide experience in Takaful industry, and before joining INCEIF as a teaching fellow, 𝗠𝗃𝗶𝗄𝗂 served as CEO at 𝗠𝗲𝗃, and he sat in various boards at industry level. So I would like to start our discussion with Ms. Iliana. So please, Ms. Iliana, help us understanding this issue. Why our medical costs increase and we experience medical inflation? Is it because of the treatment cost increase, or it because of the excessive hospital charges charged by the hospital, or because of the inefficiency of our medical or our ecosystem in Malaysia? So please.
Assalamualaikum and good afternoon, everyone. First of all, I want to say thank you for having me here. It's an honor, and as you heard, my background is a bit different, so maybe my perspective is from the outsider's perspective, and maybe also for the layperson, whoever's joining in. I think all of the factors that you mentioned just now do contribute towards medical inflation. And this issue of medical inflation is not unique to Malaysia. It's also something that's happened on a global scale. But it's happening at a higher rate in Malaysia, 12.6% expected in 2025 versus a global average of like 7.2%. So one of the major factors that's driving this increase, I think we can talk about population aging. Malaysia is expected to become an aged society by 2045. And although we've achieved great leaps in terms of longevity, we've not exactly achieved these access years in good health. So for example, if you're 60 to 64 years old in Malaysia, 25% of your latter years are spent in poor health. And if you're 80 to 84 years old, then 35% of those years are spent in poor health. And this poor health is associated with higher healthcare spending and more healthcare demands, especially associated with things such as non-communicable diseases, such as cancer or cardiovascular disease. So countries such as Thailand and Singapore, which have already reached the status of aged societies, do have a higher than global average rate of medical inflation as well. And another factor that's driving the medical cost increase is the advancements in technology that's available in the market now. So there are certain cases where previously there were no medications or treatments for certain disease, where now there is. So for example, retroviral therapy for HIV, or where a wider population benefits and thus can demand more healthcare. For example, vaccinations for new diseases such as seen with COVID-19. So the rise in medical costs is expected because of these kind of development in healthcare. And I think Malaysia is also relying on the strength of the ringgit because we do import a lot of our healthcare technology. In 2020, I think we spent about 1.3 billion USD on importing medical technology, and 70% of that comes from the United States. Another driver I think that I just want to quickly mention is the buffet syndrome, which has been cited by authorities as a reason for medical costs going up. And buffet syndrome is where theoretically the person who has like a zero copayment or a full rider policy tends to utilize more healthcare services because they want to maximize their benefits coverage. But I do feel that I want to caveat that there is not a lot of robust data that proves this occurring at a large scale in Malaysia. So to use blanket policies to target this may be a bit, we should be wary of doing that, and instead be looking at things such as excessive costs by healthcare providers or procurement of pharmaceuticals, or even the exodus of our healthcare workforce, which means that we're paying more for the remaining healthcare workers that are available. So in a nutshell.
Alright, okay. Let's respond. Jasmine, So, having said that, so how is the Takaful provider respond to the rising cost of medical treatment? Do you absorb the increase or the cost, or you just pass them to the consumer?
Okay, Bismillahirrahmanirrahim. Alhamdulillah, wassalatu wassalam ala nabiyyina ajma'in. Assalamualaikum warahmatullahi wabarakatuh. Okay, question is whether we pass the cost to consumers or we absorb, or can we sustain that? It is very interesting question, because things like people tend to think that we pass the cost to consumers. Not really the case, actually, from practitioner perspective. When you design the product, you have capital to support. And from Takaful perspective, you got a risk fund you have to look after. Okay. And you got to balance between these two. As you take on more risks from practitioner perspective, as you write more medical, the risk exposure is getting higher and higher. And we are obliged to support those risks with capital. And the cost of capital is definitely coming from shareholders. That's number one. But at the same time, when you design the product, when you do the pricing, when we do the pricing, we assume a certain inflationary rate, especially medical. We know for sure medical inflation is not going to be like a single digit, like a general inflation. No, we know. But then, as we design the product, we have a limitation. Okay, so whether we like it or not, whether we like it or not, the rising cost of medical will have to be priced in, so that our type of fund, risk fund, remain solvent. So it's a sharing. So the question now is whether it's sustainable or not under current state of medical inflation care system.
Yes.
So it's not. The thing is, if you look at the way we design practitioners, I have some experience designing all these medical products in the past. If you look at the evolution of medical insurance, the way it was designed, okay, there's a lot of factors when we design our products. Historically speaking, in the past, we had inner limits, for example. It's easier to control. Inner limits means like, okay, you're hospitalized, certain procedures you're subject to 10,000 on. Certain procedures 15,000. You break that, you have to pay yourself. Right? Then, as we evolve, insurance company, Takaful companies become more sophisticated in terms of, the risk assessment and all that stuff. We make it as charge, for example. So the trouble here is as charge. As charge means, if your annual limit is 100,000, you can just break the 100,000. But do we price it at 100,000 utilization every year? No, because the concept of the pooling of risk is being, basically calculated. But the point here is the inflation, the medical inflation, which is going up, you can't control it. Whether you like it or not, your assumptions at the point of you price your product may not be sustainable anymore. You see? So that's the reason why we have to reprice the product. We have to reprice the premiums from time to time to keep up the medical inflation, to ensure that the risk fund remains solvent. And don't forget, I did mention earlier on, every risk that we take has to be backed by capital. And the capital is the cost to the shareholders. So in a way, it's a sharing. You see? So I think I've answered that question.
Okay, thank you, Jasmine. I think the key word is to strike a balance between profit and social protection. So looking at the the model of Takaful business, Jensen, do you think that we need to propose a new model to become sustainable?
Still no. And then precisely the question. A question. Now we are talking about Takaful. Okay. In Takaful, as most of you know, the insured, which is the participant, is also the insurer. A couple of criteria are mere managers of the Takaful fund. So, proper question just now. If the cost of the medical cost is increasing, who should bear the cost? The insurer. Which is the insured? That's the model. But the corporate actually, this is why always says in semi-finance, you talk about resharing. Resharing among the participants. So every time comes to Korban, the cost of a cow is increasing every year. We make a big fund where we want to sacrifice. Now it's $1,000 per share. Other places about $300 or even $400. And I know last time was even less than $500. Every year Korban gets now. Do we complain? We still do that. Tabano? The Takaful model is on basis of Tabano with the standard cut for everybody for the medical fund. If cost increase, right, we should have to pay. That's what the Takaful model. So if you are asking now, should we change that model? We'll go back to insurance. When insurance become the insurer and taking risk of whatever risk, higher claims or higher escalating cost of claims. So which one do we want? We want back. So maybe, and I know this topic is hogging up limelight, but maybe for the audience, even in Mr. Anna paper, private healthcare cost from insurance or even Takaful only pays for 8.3% of the Malaysian cost of medical care. It's a small, but this thing has been subject of parliament, debate, newspaper and media. And of course, Takaful has always been lumped to insurance. Whereas actually insurance, Takaful is not insurance. So that is it. The industry becomes an easy punching bag. So I mean, to me, the big question is just whether that 12%. I mean, in some reports, based on the study, it's 15%, much higher than UK cost. The closest is India, if I'm not mistaken. But much higher. Is that inflation, medical inflation, justifiable? Yes, non-communicable disease have increased. Now, 50% of nation are obese or overweight. 1/3 have hypertension. 20% of nation have diabetes. Who's at fault? Where the best medical care, obviously, is our own fault. Coming back, looking from a Sharia perspective here, and Takaful being in Islamic finance, Maqasid, life is second to religion. Al-Raf mentioned eat and drink healthy, but not in excess. How many of you are doing that exactly? So, non-communicable disease, as she mentioned, have increased. In 2020, 7% goes to hospital. 3 years later, almost 10% goes to hospital. So of course, now the big elephant in the room,
maybe rather than asking does the Takaful company, which is really a small player in the whole scheme of things, should government regulate medical business? Because coming back to the question, how do you want to manage this? Cost escalating? Yeah. And I can tell you, I mean, I've been in hospital and now I got 7 doctors in just in one hospital. Which this hospital I go to, I got 7 physicians to attend to, respiratory, all these kind of things. Yeah, sometimes you can negotiate. If you're going to pay yourself, you can negotiate with them, they'll lower the cost. So what is the true cost? 70% of the cost is on hospital and surgical supplies, services and supplies. That's also the make. Doctors pick up for the other 30%. So we should want to regulate. Should hospital, if you buy medicine in hospital, it's 20% more than you buy in pharmacies. Should they be dispensing medicine as a cost especially? So I mean, these are the things to be looking at. There's a much bigger picture. Alright. So on the Takaful model, should we change, coming back to your question, be based on Islamic finance principles? We have to change, but everybody have to understand and also contribute. And also, and this is where I think they found one of things that really in Takaful structure we got to change is the upside of Takaful. I think, yes, you mentioned I'm a director, I've been betting, and maybe that when we started, when we got readily want to participate in Takaful, we must say that the akad is based on the tabarruk, which is a donation, but you do that because of subhanahu wa ta'ala. Just like if you were to pay zakat and pay akad, based on inna salati wa nusuki wa mahaya wa mamati lillahi rabbil alamin, all our ibadah is for the sake of Allah. So when we take Takaful, it's the sake of Allah. Allah will determine whether we're sick or not. But unlike in the insurance, I read an article where a person started, of course, after paying and paying, if I'm not getting anything, I assume that all the contribution happened in the past is like the same. So they should not be increasing prices or interest stream. But in Takaful, it's different. We pay, we don't get any claims or we don't claim, we should be saying thankful to Allah. Alhamdulillah. There's no loss. So I would think we should change.
Okay, thank you, Mr. Izzat. I think you make a very good comment on the regulation of the hospital. So Ilyana, based on your research, do you think that it's a time for Malaysia to consider government intervention on the or to regulate the hospital price and the drug price in the market?
I guess the straight answer would be yes, but I know that a lot of political will is needed to interfere in the private market. So one option, I guess, would be to take the legislative hammer and say, yes, we do want to regulate prices because, as mentioned by Mr. Izam, 70% is unregulated. The medicines, the consumables, the nursing, the ward charges, those are unregulated. The only thing that's regulated is the doctor's consultation fees. And perhaps if we were to mitigate the medical inflation, it would be through the legislation amending our Private Healthcare Facilities and Services Act and saying that these things will also be regulated, whether the MOH would set a price or whether we're using value-based payment models, perhaps such as diagnosis-related groups or any other kind of payment mechanism that pays based on the outcome of the patient instead of a fee-for-service. So right now we're using fee-for-service, a line-item-based way of paying for healthcare services, and that leaves room for overcharging and overconsumption. So perhaps looking at the way we allow healthcare providers to charge us. Another way besides using like a strict legislative way would be to encourage healthcare providers to transparently publish their prices or costs on a public domain in order for healthcare, in order for the patient to be able to look it up and be able to compare between providers to see, you know, how much does my procedure actually cost and make better decisions. Because right now, I think the only thing that is disclosed by private providers are the room rates. So the other things that are related to your procedure are sort of vague. And I think we can see definitely there's differences in terms of charging between paying claim patients and also guarantee letter patients. So one number would be for pneumonia patients. For those who are paying claim, they're charged about 1,288 ringgit. But if you have a guarantee letter in the private sector, you could be charged 4,978 ringgit in contrast. And if you're without insurance, for example, for cataract, you can be charged 3,000 ringgit. But if you are on insurance, they can charge you 6,000 ringgit. So this is actually something that we should be looking at, and we shouldn't be accepting that this is happening where people are charging differently based on, you know, whether you have coverage or not. Yeah, so that's the short answer to that.
Yeah, this Khazanah, do you aware with these differences? Those who without and with policy, Takaful policy, that then, you know, if this cost is keep increasing, so maybe we can reach a point where only those who afford, who can afford to pay for the premium can have Takaful policy. So are we going to that direction or half?
Okay, let me just speak my mind. I think it's time to just throw away all the scripts. It's right to see what I said just now. You know, the cost of treatment between a patient who has insurance and without insurance is three times, I think I'm mistaken, if I look at your stats now. And your question is, are we aware of it? Of course we are aware of it. We know that. We as ITO means insurance and taxable operators, yeah, we know that we do analytics. I can tell you based on my experience in the past, even now, when we do the analytics, we know the drugs, the cost of medicine, if you buy from the hospital 3-4 times. And the first question, maybe a bit controversial there, I call another use. I wrote, I run to public hospitals. The first among the questions that the doctor will ask you, or the hospital will ask you, when you go and see them, what's the question? Exactly. Do you have insurance or not? What is the relevance of this? Right? I'm very sure in this room, or even those who are listening today virtually, online, I'm very sure all of us have gone through that experience. So the question about where do we head? I always say this here. I don't know whether we are a victim of the situation here or I don't know, we create this problem ourselves. Okay, and like I said, I'm going to speak my mind. I hope I'm still going to keep my job. you see the system that we are in today. I don't mean to criticize anyone. Okay, I've been still a trainer. This is where the government hospital is, right? And this is where the private hospital are today. The question that we have today, we've been preaching. We go out, we tell them, this is just like a hadith says that, the Buddha lima, get the 5, seize the 5th, the 5 things before you datang lagi kan. Antaranya among those are when you're still young, when you're still healthy. These principles are basically applicable to Takaful. You buy life insurance, and at the time that you really need your medical coverage,
that is the time that you cannot afford. This is the system which I don't know what has gone wrong. Because if you look at the entire ecosystem here, that I did mention, because this morning I had another interview actually. I said all the stakeholders have a role to play. Let's not blame each other. Insurance company or Takaful operators, they've got a role to play. The way you design your product, the way you price it. Hospital, private hospital, you got a role to play as well. Control it. But how many hospitals today look like hotels? I'm making some very point blank statement. You know, the thing is, I gave you one example because, you know, in STM, when we gave out the medical benefits to the staff, and the staff just love to go to the 5-star hospitals without naming them. I think you know which hospital I'm talking about. The ones who have coffee bean, the ones who have, like, you know, all this. I think you know what I'm talking about. Do you think it comes for free? No, it's not free. Those are contributing to all the factors that we've been talking about. So we've got to control it. You got to regulate. The trouble is we have one at the top, one at the bottom, and nothing in the middle. This is my view. You know, it's like those days when you have Malaysia Airlines, you have Singapore Airlines, you have all the, you know, and then the next is you have AirAsia. That disrupt the entire piece, right? Brings down the cost. That is one way, maybe. Maybe another way of looking at it is maybe you have to design a 2-tier. I've been thinking about maybe there's a 2-tier of medical product have to be designed, medical policy or insurance policy. One with a referral, one you can go to the hospital as you like. Then you can control the premium against. The control mechanism has to be there, but unfortunately today is missing. You know, I think you need to be better on that part. I don't know whether I've answered your question, but basically this the reality that we face today.
Yeah. Okay. Thank you, Jasman. I think in Malaysia,
Can I
yeah.
come in? I think what Jasman is correct. And I think changes have to be imminent. Not in the Takaful space only, but also in the health system. Okay. Maybe to address, firstly, you're talking about 2-tier, yes. Basically, or basically the way that maybe Takaful is medical Takaful is managed should be managed like general Takaful, like motor Takaful. Not to be, it should be able to stand alone. Okay? So, and especially because of the high demand. Then, that, you know, one way can help to reduce costs in terms of procurement, or make it, I think in the Lena's paper talking about make it via digital, very easy. So you really can reduce the cost because you take procurement costs or commissions that otherwise have gone to the intermediaries much lower. Because it's demand, so like family Takaful, life insurance is not so demanded, so the agents got to push and sell. But if it's very demanded, one will just go like motor Takaful, because you need it, otherwise your motor cannot go road. You go directly, even for that matter with one company which I participate in, I get 10% discount. Because I paid directly. So we have to reduce cost, certainly. Because part of the pricing is not just the claim, but also cost. I think for those who attend my class, we have to put in because of cost of family and so forth. So you can reduce the cost. Now, interestingly, Jasman may talking about 2-tier, yes. There's such thing as major medical and the normal GNS. So maybe we should provide major medical for, and this is where I'm talking about really, if you're thinking you're going to have cancer, whatever, then you can repay for that. Now, most of what we have right now, even an issue, are actually covered by most employer. If you go any company to work, you will already have group Takaful paid by them. So there will be redundancy actually. So maybe if those proper coverage, of course 25% of our workforce, what you call gig workers, they are self-employed and things like that. There's still some issue on that. Now, so there are some restructured costs in terms of the product that is done. Now the other part here, this is why I'm talking about change system. Jasmine put in, yes, when you are young, your premium seems to, contribution rate is lower, and you can pay, but your chances of getting sick is likely less. Yes, in US, a person age 65 spend 5 times more on healthcare than the average worker. 5 times. If the average worker, if you are young here, spends like maybe $1,000 on healthcare costs. If you are 65, you spend $5,000 on healthcare costs per year. Now, this is where I feel, and we have actually a component, and this is what we call in other countries like NHI, Medicare, whatever. Here in Malaysia, if we have the EPF, for instance, there should be a third account rather than a third account which you can take out and weigh, just purely on medical fund or medifund or medisave. Jasmine, that's it. During the working years, you can save whatever 1%, 2% only. If you want to, if you're in need, you can take it out. But if you don't need, this will build up to when you really need is when you're retiring. Who's responsible for retirement benefits? Ourselves. When we retire, who's supposed to pay for retirement benefits? So we better save today for retirement, which include medical, a major portion of it, like 60%. And then you can correct me if I'm wrong. But around 60% of when our retirement expenses are spent on medical. So better save it right now. You don't have to pay to Takaful, or maybe you pay to a fund managed by the government, compulsory. I mean, this is something you need to introduce. That's what I'm thinking. While you're working, you have your company. If you want extra, you have a major medical. Even the deductible that they want to introduce can be integrated, because in medical coverage, whether insurance Takaful, you cannot claim from 2 policies. That's what we call contribution clause. Because you're not supposed to benefit from insurance Takaful, you only to be compensated for what you lost. If you have to spend 10,000 on medical at a hospital, even though you have 2 contracts of coverage, you only can get $10,000. So if company is paying, then you basically you will not be claiming under your Takaful plan. So the pricing can then become affordable, because the deductible, so-called, is deemed to be coming from the employee scheme. So when you design the scheme, you take in cognizance what is already afforded to you by other means. So that seems have to, in other words, or basically, if you have a company plan, your pricing just now, you're talking about, do not necessarily have to increase.
Okay, Kezam, I think what we established here is that we have these 2 tiers of hospital. We have a public hospital and we have a private hospital, and the difference between these 2 is very huge. Okay, and then some researchers suggest for those who cannot afford to take up or to pay for premium for Takaful, then they suggest wakaf to be imbued in this Takaful product. So what do you think?
Okay, firstly on the part, Jasmine says public hospital is this, private hospital is this. But do you know that in Singapore, the public hospital is the benchmark? And also in Malaysia, I've been in a public health hospital and also been in a private hospital. I had motorbike accident. I was in Kajang Hospital, I was in 𝗧𝗸𝗃𝗃 Hospital. Their care is as good as a private hospital. maybe you say, no trimmings, right? But I'm sick. But if I need to urinate, excuse me, doing this, but the nurse still come to me to help me out. So public healthcare, and if you ask, my doctor works in, she's trying very best to give very good healthcare to people who comes in. And it's just that there are so many more people, I think Elena can give you the numbers there, going to public because of the cost. And maybe looking at the budget issues, the overstressed public healthcare that we have here, maybe it's high time the government also increase the cost of healthcare and going to public hospitals. No, true? Yeah. Of course, they have to find, the budget for this year is only 10%. Much lower than what they call middle economic countries, middle income economic countries. Much lower than the average from those kind of countries. So we have to increase our, of course it's through taxation, but we need to increase also because we actually, if you go to physiotherapy in Selayang Hospital Public, it's as good as also the physiotherapy that I go in a private hospital. Healthcare in Malaysia for pregnancy is good, but just too many people and talking about the waiting line. So that's one thing. Now, the question, yes, I do agree. In any kind of health system, so you have government taxation to pay for primary care and healthcare, then you go to the compulsory, which I was talking earlier, maybe for instance you have MediSave, where you can basically put in some money and you save for retirement, healthcare costs or whatever, and then of course you go to the private, and then of course you go pay your own out-of-pocket expenses which you pay out yourself. Yes, the finally one, what they call, as you say, the wakaf or by donation or charities or what they call 𝗖𝗀𝗀𝗃, with the public wakaf. Maybe the religious council of each state also got to do this part to start it up. But of course, to me, there will be some eligibility requirement, target for the lower income or the 65-year-old. In Malaysia, those people who are retiring are now asking for zakat. More and more increasing. The number of people asking for zakat, the number of age is now. If they have very limited funds. Medical lagi. So they ask for zakat. So now why, rather than manage at the end, maybe we should start contributing, but the eligibility will be strict, and also only for citizens of Malaysia. Not being unfair, but sometimes charity begins at home, just because it started over time maybe when you get donation. But every state should have that to supplement, in other words, to provide for this group which are really in dire need, that portion. So it's right, of course, each state have to provide it, and then you can put in some zakat. Of course, the zakat got to be used for that year purpose, but any other donations of course can be invested, and maybe they can work with Takaful companies to help manage the administration of those wakaf. I think Azman is aware that in the family Takaful space, not as in medical, they already have the wakaf. And in fact, people do want to contribute. There are good philanthropists that we have, but as you all have learned about crowdfunding and things like that, it can be translated back to the so-called 𝗖𝗀𝗀𝗃 or the state wakaf to help something very flexible.
Thank you, 𝗚𝗃𝗧𝗪. Maybe I come back to Azman. So I think we want to hear about the strategy, how to lower down the premium. That is what the customer want. And are you as a Takaful operator, are you open for a new business model?
Well, big question, strategy. I I think if I can just revisit my earlier points about all parties, all stakeholders have a role to play. One is definitely, if you look at the way we design a product, as insurance or a Takaful provider, that's number one. 𝗧𝗸𝗂𝗧𝗸𝗂𝗧 mentioned just now about deductible, about 𝗧𝗃𝗶𝗀. That's just one way. Okay, and one thing that we notice as a practitioner, we treat medical card like credit card. So it means that the consumer behavior has to be educated. When you have a credit card, you have a credit line for 100,000. Let's say lah. So what do? We go to shop, we know we have 100,000 to spend. If you lose the discipline, you just keep spending. It's the same thing with medical card. When you have 100,000 annual limit, you tend to go to the highest, the best hospital, even though the conditions that we have can be treated maybe at clinics. That's the reason why, if you look at the more advanced countries, like I was told recently, I spoke to one of the biggest clinics, group in Malaysia. The founder said that in Australia, even in UK, you cannot simply go to a specialist hospital. You got to be referred to. But here we are today. Once you buy a medical card from agency, from companies, what do you get? Oh, I've been paying 200 ringgit a month, 300 ringgit a month, I'm not using it. Oh, it's a loss, let's use it. The behavior itself is wrong. You got to put a control to that. You see. So that's the thing. That's consumer part. The insurance part, the way we design a product, 𝗃𝗃𝗃𝗃, without 𝗃𝗃𝗃𝗃. The hospital part, why do we have to offer the imported drugs? Why can't we use generic drugs? I'll be frank with you, personally, I have insurance. Yeah, company as well as my own personal. But every time I go to insurance, I just go to my hospitals, I've been practicing this myself. I told the doctors, I'm paying myself. And then the moment the doctor finished attending to me, give me prescription. I go and buy my own medicine. I go to the pharmacies. I buy myself. And I know I get much cheaper prices out there. And in fact, I buy just generic drugs. I don't buy the one with the branded because those are expensive. The efficacy is the same. You see, so we've got to be educated. We've got to be, the consumers have to be re-educated. The consumers have to help the industry. Rather than we keep complaining, oh, yeah, but what can we do? Because everything, the whole chain, the ecosystem we're talking about, insurance company, hospital, pharmacy, distributors. 𝗧𝗸𝗂𝗧𝗸𝗃 mentioned just now about he is sitting on an agency-based company, have to be remunerated. Everything comes at a cost. But if we as consumers, I position myself as a consumer, I position myself as a practitioner at the same time. There are certain treatments that we can go for daycare, for example. 6 hours, settled. Khalas. Why do you want to go and get yourself hospitalized for 2 nights? You are exposed to risk. Staying in hospital is not healthy. Yes. But the problem is we are sometimes we are being influenced. cik duduk dalam hospital jom malam. So these are the things. So when you talk about do we need another model, I think there's a lot of changes needed here, not just model. Okay, but I do agree. Cik Eza mentioned about wakaf, zakat. In fact, from Takaful perspective, often surplus. Millions. But we haven't done research on that. I'll be frank with you. You guys are INCEIF, huh? What's going to happen? Often surplus. What do we do? Why can't we use it? Nobody talk about it. I'm so sorry. One thing that I have to criticize Islamic finance, researchers, you guys are, minta maaf lah, I'm going to sound a bit harsh here. There's so many research on investment, on banks, but where is the research on Takaful? Here we are confronting the issues, but complain, you know. I'm sorry, I've been, you know, I was a visiting fellow of ISRA once upon a time. I have to criticize this. Where is the research on Takaful? We talk about it time and time again. Every time we talk about it, tabarok. Don't just tabarok. It's beyond that. Come on, guys. Sorry. All right. I think jalan nanti susah nanti kan.
Just to confirm, the audience today in this hall, anyone who are doing research in Takaful, please raise your hand.
Actually, they are working on this concept, but I think with this topic, I mean, we're doing on flood insurance actually. I'm doing an IEF project, but on using wakaf to assist in the flood cover. But maybe on this medical cover is something following up from here. Actually, it's much easier to do the feasibility for flood cover because for medical cover because in Malaysia, you know, we have a problem with wakaf jurisdiction. I think you know that. So essentially, every state can do it because we need the problem of medical healthcare or escalating is everywhere in Malaysia. So every state can do that. The flood cover seems to be a little bit localized, you know, the flood issues and things like that. So I think for that is much more feasible. You know, I'm not sure whether my researcher friend, I think they're not here, can change it from flood cover to medical cover. But I mean, I see it's very clear. It is very possible, and it could be managed, co-managed with Takaful companies like SDM. Is much easier, and they say with the injection of the surplus that you otherwise would given to charity for a low surplus arrangement, it can really become feasible with for medical. Rob?
Okay. So at least we have Mr. Izam who lead the research in Takaful. Okay, before I open question and answer from the floor, Ms. Iliana, maybe your last comment. What is the immediate, suggestion to mitigate or to handle this issue of increased cost?
I think that based on the comments that the panel discussed earlier, one sort of immediate action, if we want to see change, would be the regulation of private hospital prices. I think that's one chunk of it that needs to happen because that's where the bulk of the expenditure is going. But also, I think it's important to realize that, I think Mr. Azam alluded to it earlier, 70% of our population actually goes to public hospitals, right? And the services are good, yes, but they are overworked, overburdened, and a lot of the equipment is beyond economic repair, but there's no money to actually replace them. So some of them are beyond economic repair, but they're still working in the OTs with this equipment, and it's something that actually is built up over the years because every year, for example, if they ask for X amount of money, they'll only get like a small proportion of it. So it's something that needs to be addressed. And when we're talking about things like wakaf or other sources of philanthropy that can be going towards maybe donations towards public healthcare. Right now, based on how we operate, MOH hospitals are not, only a select few are able to receive funds from outside of MOF. So there's that sort of bureaucratic hurdle. So one of the things that we have discussed previously is the establishment of a national health fund, for example, which moves away from line item based budgeting, global budget coming from MOF, coming down into MOH and going to the specific programs towards like an allocated fund that they will, or a body would be able to disburse accordingly, and is open to things like wakaf, donations, if in the future EPF contributions, for example. So perhaps thinking of ways to reform our public healthcare system is also important, in line with things like Takaful or private sector regulations, because the majority of our population use it. I think in the B40, only about 13% of our population, I think this is an old number, 2019, actually have private insurance, and they usually cite unaffordability as a reason that they're not coming on. So so this small proportion of B40 is on insurance, and the majority of them are going to public healthcare. So immediate, I guess, one, regulate the private healthcare prices, and secondly, really strengthen our commitment towards public financing of the healthcare system as well. Yeah.
If I from UN, UKN, UPN, name it. You know, I'm very sure we pool all the resources, we build hospital, chain hospital based on Wakaf model. I'm very sure, I'm very 100%, I'm very sure masyarakat, the society will support. It's about time that we start thinking about building hospital, providing healthcare, be it pharmacy, be it hospital, clinics. Based on Wakaf Fund, we've got billions. I'm very sure it's billions. Maybe INCEIF, maybe fatwa, maybe we can work on it. Resources are there. I'm not saying I'm criticizing the capitalism, but the thing is, it's about time that we move away from this. We help the nation. We build the hospital using all the resources that we have. Why not? From Takaful perspective, we can provide the right pricing. We can help channel the participants to the hospitals. That's all I request, if possible. Somebody just come up with the research. Then we go and talk to MOH. You talk to Medical Takaful, let's build hospital. Why not?
So far, Jasmine, we do have only Wakaf clinic. So championed by Wakaf Anur in Johor. They have
but KPJ is also under Wakaf Anur. So but how is it being done? So I think, of course, this is where the management, the healthcare system could be looked. I think that task force, whatever. I mean, so even whatever you set up, the management is important. The Medicare fund, but I'm just doing what they call the quick, low-hanging fruit, changes. So knowing that it's a responsibility for all of us to take care. As Muslims or as individuals or whatever, we have to take care of our own. We have to contribute to it. So just retirement, healthcare. I mean, many people forget when it comes to retirement funding, they wait until they are 50, then we start trying to save for retirement. By that time, it's too late. So only, as what you said just now, the 5 things that you must do before the 5 things that comes. Don't wait until it's really sunset for you to do the preparation. So even, you know very well, 60% of your medical, your expenses after retirement will be spent on healthcare. So better prepare now. So while you can. And I think, that's a responsibility for ourselves or for our family and things like that. So I think this education, and also I think for the Takaful industry per se, I think we need to voice making people more aware about your difference with insurance, and not let you be a punching bag in this arena, really, because you're only a small contributor on the healthcare program. So the real big elephant there, regulation on healthcare costs.
Okay, thank you, our panelists. So I think our discussion now expand not only we talk about the cost crisis of medical takaful, but we also touch about the public health in this country. So now open for any question. Yeah, need to give the mic to. This okay.
Assalamualaikum. I'm a researcher here at INCEIF. I've got 3 questions. But I'll keep it short. And so first is medical inflation and repricing rates. So Malaysia's medical inflation rate in 2024 is 11.9%, higher than our neighbours. Indonesia 10%, Singapore 9.5%, and Thailand 7.1%. It's higher, but not that much of a difference. But Malaysia's medical repricing for insurance is 20% or higher, which exceeds the medical inflation. So is the trend similar for Indonesia, Singapore, and Thailand? And if not, why? Second is takaful versus insurance. The second question. So takaful operators appear to be more affected by repricing compared to conventional insurance companies. So if medical inflation is the primary reason, shouldn't both insurance and takaful experience similar increase in tandem? Yet takaful operators have undergone repricing exercises more frequently. The third is GLC-packed hospitals. So 35% of hospitals in Malaysia are GLC-packed or have substantial GLC shareholding. Given their role in national wealth creation, they also have a role in social responsibility. So what role do they play in ensuring healthcare affordability for Malaysians? Should they have a more active role in controlling medical costs? Those are my 2 questions. Thank you.
Okay, thank you, Mr. Wan. Can we give a mic to our brother here in front?
Alright, so I'm 𝗂𝗃𝗧𝗏, right, student here at INCEIF. My question is for the esteemed panelists, general question, right? So I think I came in here with a number of questions, but now I'm going to be leaving with 1,000 more, right? In a positive sense, right now I'm much more curious and interested in takaful and what's going on in Malaysia. My question is, for just a background, in the US, right, this new administration has spoken about essentially reforming, right, the healthcare system, right? And one person who is particularly keen on reforming is billionaire Mark Cuban, right? So he talks about how the PBMs, right, the pharmacy benefit managers, right, which are essentially the middlemen or the intermediary between insurance companies and the drug manufacturers. He says that they have a huge role to play, right, in the problem that is going on in the US. I just wanted to understand, perhaps in the case of Malaysia over here, how much of a role, how much of a blame, I should say, right, are on these particular individuals. Right, I understand Mr. Azman, right, Azman has highlighted that everyone has a role to play, right, even the sick people themselves, right, they're really planning, as Mr. Zamsha mentioned, would contribute to the increasing prices and whatnot because of their late savings. So my question in particular is on these PBMs, right? How much of a role do they play in the current crisis, and what perhaps would be some of the countermeasures to addressing the problems they've caused? Yeah.
Okay, thank you. We do have 4 questions. We take 4 questions first. First, on the medical inflation rate and compared to the price in between Asian countries.
And second is regarding the Takaful versus insurance. Why only Takaful price is increasing? And third is about the ownership of the hospital. Most of the hospital, private hospital in Malaysia is linked with GLC. So what is the role of hospital, GLC linked hospital? And fourth is about the reform insurance or public health in the US, how it affect, what can be learned from this recent development in the US. So maybe Yana first respond on the first question.
The first question in terms of repricing, I might not be the best person to answer this, but I do understand that our repricing cycles are not too frequent. So that's why at a certain point when we reprice, it will be a bit higher than the inflation because it's basically accumulated over the past few years when you reprice. So yeah, once every 3 years.
Repricing is normally done once every 3 years, not every year. So inflation rate, what's measured is every year. In fact, the number our medical inflation, actually what you cited is much lower than even Liana's or what I got from other sources. Aeon will be best repro, it's more than, it's around 12% or more. So if you have 12%, 12%, 12%, in other words, you cube 12%, there will be something what Takaful companies are wanting to increase. Okay. So on the second part, insurance is also repricing as well, not only Takaful, but some what limelight seems to be the Takaful industry. Unfortunately, again, as mentioned just now, even both contribute only to 8% of the financing of the care. So, yeah. And the third question, I think anybody from GLC to answer.
If I can supplement the answers given to you. On the, first of all, this repricing cycle. Repricing cycle, every company, insurance or Takaful, they have their in-house policy. It has to be approved by Negara. Whether it's 2 years, 1 year, 3 years, but normally, typically, it's a 3-year cycle. Okay, and our stats shows is basically our medical inflation is 15% per year. Not over 3 years. Okay, so the frequency of repricing is really pressing actually. Okay, because when you look at the risk fund, when you do your valuation, you got to know where is your threshold, your loss ratio. In the technical term, we go A over E, actual over expected. So when you do pricing, your E is actually your double charge. What you collect from the participant, park inside the risk fund, that's, let's say 10 cents. But what is your actual cost that's incurred? So as a practitioner, we're going to measure the A over E all the time. And we're going to be monitoring that, whether it hit 100%, 96, 90%, 120%, whatever. So each company will have their own threshold. That is one. Now, number two is very interesting question you asked about why Takaful seems to be doing a lot more repricing compared to insurance. Okay, this I'm going to be sharing my own personal experience in the past, which I cannot mention which company. Okay, you take a guess lah. Takaful is being sold as one family. A lot of times, agency force, they tend to sell the Takaful policy to the whole family. Father, mother, 3 daughters, or 3 children, whatever. And we observe at the time, which I believe is still true, we observe at that time those who are having infants, especially 0 to 5 years old, the claims from the first year spike straight away. Based on my past experience, which from whichever company lah, I don't want to mention which company lah, Okay, 1/3 of the claims came from that group of participants, 0 to 5. And we observe from insurance perspective, this is the difference, the demographic profile of the customers. I observed this personally. I say, hey, how come? It's something that we learn actually. It's different. So 1/3 of the claims happen in the Takaful. I just want to, maybe it's a specific company I'm talking about, but I believe it's the same with other companies. Even right now, I'm just sharing with you. I got 2 medical products. One product which I'm selling right from age 0 all the way up, 50, 60 years old. One product I sell only age 6 years old and above. You know what happened? The product that we offer from age 0, right from the first year that we sell, straight away the claims spike 30-40% in the first year, compared to the product that we sold, that we've been selling from age 6 onwards. The claims is still highly manageable. You can see that this is the statistics actually. Okay, on the third question about GLC, I don't think I can comment lah. I think I think this requires a lot more. Maybe Khazanah can lah.
I cannot speak for now. But I think if you're reading public publications in the news, what they say that they're giving back to the nation is through medical tourism. They're bringing back money in that way, and I guess through the investments. But I think there is definitely room for them to do more philanthropy kind of exercises, especially because they are funded by GLCs. But that is something that we should push for.
Okay, we receive a lot of questions from online.
There's a question.
Just to relate, because one of the questions asked about the same thing. He said in 2023, private hospital in Malaysia earned a revenue about 27.73 billion. So the question is, who get the benefit? So do Takaful participant benefit from it? And can we structure a musyarakah so that participants can also benefit from the profit generated by the private hospital? So I think more or less it's the same line of thinking. And we have this Mr. 𝗏𝗃𝗧𝗏. I think it's very interesting. He suggests, can ITO come together and set a common tiering standard for private medical center? And because he see that this can be effective to put a limit for the medical inflation. So maybe Azman, can you respond on that?
I think that's question. Our brother's question we have not.
Okay. Oh, sorry.
Yeah, it's okay. What we can learn from what's in the US. Of course, you have your Medicaid, and you have Kaiser plan, you have TPAs, you can have preferred providers. I think those things are nothing. If, for instance, like these are somewhere in between public health and private health. So yes, you could have those where actually it's on the mutual concept, and this is where maybe later on, if you have the workup or several, you can have those kind of hospitals which are really no frills, has a 5-star hotel beds and things like that, But again, Malaysian consumers, they are demanding, they want everything. For instance, you ask many ladies here, if you are giving birth to a child, how long do you think you should stay in hospital, ladies? US 1 day only, then you get discharged. Are you willing to go back to after giving birth? Tomorrow you leave hospital. You don't need to stay in hospital anymore. So this kind of things. So even if you have the no-frill hospital, which actually there are some, then people willing to go. So some issues with the consumer as well. and maybe even with the Takaful plan, I think they're going through some changes, I know. As what you're saying, can you make a claim even at non-hospitals or no-frills hospitals? Like you say, you don't have to stay there long. But recently, I went for my knee injury to a clinic which are qualified for my PRP, or of course without any reference. If I go, and cost I think easily 1/3 if I were to go to hospital. But the insurance the Takaful company says I cannot claim because this is not a panel. So maybe I think this is where the Takaful is expanding into inclusion of some so-called clinics which are actually equivalent to treatments at hospital as well. Right? So some people say if it's in hospital, then it's not recognized claimable treatment. So I think these are some things that change, you know. But of course the TPA, the second tier private hospitals or managed care, what you call it, right? It's something that can be looked at, you know. So, you know, okay.
Any comment on regulation of medical costs among the private hospital? Maybe the suggestion for the ITO to come together to try to regulate instead of the government.
Okay, I think one of the action plans agreed with Bank Negara, in the midst of all the big hoo-ha that happened back in December even till now, is to come up with a affordable basic medical plan. And if you notice, MHIT guideline last year, medical health and insurance in Takaful, MHIT guidelines issued by Bank Negara, policy document. It says there, ITO can no longer sell or issue a new product with a full coverage. That's a big move. If I'm not mistaken, the core Takaful or deductible is 5% or subject to 500 ringgit, something like that. You can just look at the Bank Negara PD on this part. So whether we like it or not, Bank Negara has already started regulating the medical product design. Everything has to be on core, even for those companies who are still offering full coverage. Okay, it's compulsory that we offer that product with an option of core Takaful or deductible. So that's number one. And number two, I think we are still in the discussion at the moment, coming up with a basic medical plan. Okay, and one of the action points is whether we can allow migration from the existing policyholders or participants to this plan. So all these are ongoing, not an easy thing to do. Coming together is one thing, but you must remember systems, you must remember the pricing, all that stuff, data. So it will be a journey still. Okay, I hope I've answered the question.
Okay, thank you very much. Any last question from the floor?
My name is Khazanah. Actually, I'm from the ground. We are Medical Takaful agency. So basically, yeah, whatever is happening actually is happening. But for me, as an individual, and dealing with the client is actually a big headache, because whenever happening in the market, we are the first line. We receive a lot of messages, and my client is more than 100 portfolio. So now I was thinking, like, for the future, I mean, like, like for the agency, right, we have the PR ratio that we have to maintain, and then it's a bit also challenging for us. And then, before that, this whatever is happening right now, we have the issue on the underserved people, and we have the issue on the retirement people, and then we have the effect from the MTA under the paper, their paper, which is they are looking into the collaboration with the EPF to cater the risk market, and then also the wakaf is another one is actually looking at the underserved. But the thing is, now I was thinking like, if let's say it's going to be happen until like no control, actually it's going to be, these two population will be increased, and then at the same time it will be affect the whole chain. I mean, like me as personnel, as the salesperson, we also will be affected. So I just want to know like the effort right now. And then, you know, hospital always silent. Whenever it's coming, they will always silent. And last week we have the discussion with the CEO of Scott, and they listed from the PIA panel, and then also recently too also listed Scott as a panel. So also, again, we are not discussing about the price, but we are still discussing about the method how the client can still go there while they're having the pay and claim. So now I was thinking like to make sure that we as an agent can sustain, and then client can sustain their policy, and then at the end of the day, the company can sustain. What would be do you think your own opinion that it can, like the collaboration, and is it you have the collaboration with the hospital to come up with the current effort that you have with the hospital to get the agreement for that? Yeah.
I think many Takaful companies or insurance companies are reviewing so-called panels for hospitals. Yeah, I mean, but that's why I mentioned earlier, maybe we should treat this like a motor product, where if because of the high cost of claims, then they go into approved panels of workshops only. Of course, there's another issue there on anti-competition. Becomes an issue with the Commission of Anti-Competition. So, but if you look the panel, and you're right, there are not only Prince Court has been taken off, but some other very expensive hospital has been taken off many of the panels. So with the panels, I think that must be done. But of course, as Azman says, the way that the insurance or Takaful plans has been modified, or escalating. Last time there were all limits, but now blanket cover. So basically you're asking for trouble. So now there's, in other words, the reformation, yes, Takaful or insurance company also got to change the way they do the things or do the products, and then and how they administer it. Certainly for the agents, even for instance, there is a slight reduction of commissions, but on the product which is very demanded, wouldn't the economic way, if the demand is high, price should be lower? So if it's easy, has to put literally sellable, then not much effort is being done. So then basically you can have a lot of volume for the same effort. But if you are doing the life insurance or the family Takaful just on the death cover, there will be a lot of posting and the time cost and spend. But this is a very demanded product because the demand is high. So maybe with you have greater volume. So if you sell separately, your quota could be modified from the company. That if you have more quota on your quota can be also contributed by the medical standalone. So maybe these are things which actually also need reformation. I mean, I don't want to go into details so much, but the company. But of course, we're talking about fairness, justice. I think for all, or basically inclusivity for all. So customer ada, got to look at hospitals also got to do their part. Even somebody was saying about, how can meditourism contribute back to the? It's a big question, but this is what the GRC is saying. So there are many questions. But I think everybody interested got to be looked at, but everybody got to have an open mind on it. Okay.
If I can just add to those answers, right? Actually, all the ITOs have always engaged hospitals to negotiate on the price, on the drugs, everything. And that has been going on for many years. But still, whatever happens today, you just spiraling out of control. Okay, so I think the only way is we have to regulate. Choice, we got to regulate. That's my view.
Okay, I think we come to the end of our intellectual discourse. Thank you everyone for all your contribution, especially our panelists. I'm very glad to hear very frank and very, I should say, truth, insight and opinion from our panelists. Have a wonderful day, and I look forward to your contribution in our next intellectual discourse. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.